Meet Marcus. He is a 52-year-old petroleum engineer who just returned to the United States from a 4-week trip to Nigeria to visit family and friends. Look at this timeline. Exactly 12 days after his return, Marcus presents to the emergency department. He is hit by a sudden, violent systemic paroxysm. He is suffering from profound rigors, a severe frontal headache, and a fever spiking to 104.2 degrees Fahrenheit. That precise combination, recent geographic exposure in West Africa, a 12-day incubation period, and a violent systemic onset, is the textbook presentation for a highly virulent Plasmodium falciparum infection. Marcus made a critical clinical error. Because he grew up in Nigeria, he assumed he still possessed lifelong natural immunity, causing him to skip pre-travel counseling and prophylactic medication entirely. This graphic highlights the immunity myth. Natural immunity to malaria requires continuous exposure.
Moving to a non-endemic region causes protection to wane rapidly, leaving returning travelers vulnerable. Furthermore, West Africa is highly endemic, accounting for 70% of all imported U.S. malaria infections. Relying on outdated natural immunity transformed a routine family visit into a life-threatening exposure to a drug-resistant parasite. Initial routine laboratory tests show mild thrombocytopenia and anemia, early indicators of hematologic involvement. This rapid diagnostic test, or RDT, is immediately performed. The positive PAN line indicates the pan-malarial aldolase antigen, confirming a Plasmodium species. The secondary finding is more specific. It's positive for histidine-rich protein 2, or HRP2, exclusively isolating Plasmodium falciparum. To confirm the species and quantify the infection, we examine this thin blood smear under light microscopy. Notice the morphology. The red blood cells are normal-sized, and many contain multiple delicate ring-formed trophozoites per cell. These specific biomarkers and microscopic hallmarks provide a definitive diagnosis of acute, uncomplicated P. falciparum malaria. Because Marcus shows no signs of severe organ failure, we can proceed directly to targeted pharmacological intervention. For decades, the standard treatment for malaria was chloroquine, but because Marcus acquired his infection in West Africa, chloroquine will fail due to widespread parasite resistance. In a susceptible parasite, chloroquine freely diffuses into the highly acidic food vacuole, preventing the parasite from crystallizing digested hemoglobin into toxic free heme. This effectively poisons the parasite with its own waste. The West African strains of falciparum, however, have evolved a genetic mutation in the PFCRT gene. This diagram illustrates the mutation's result, the PFCRT transporter. Acting as an active efflux pump on the food vacuole's membrane, it aggressively captures protonated chloroquine molecules and ejects them. The drug is cleared before reaching the threshold needed to bind toxic heme. By continuously pumping the drug away, the parasite safely digests host hemoglobin and survives. Chloroquine monotherapy is useless here, necessitating a dual drug strategy. To overcome this resistance, the current standard of care relies on artemisinin-based combination therapies, or ACTs. For Marcus, the prescription is a combination of artemether and lumefantrine. The first phase of this attack is artemether. Acting as the pharmacological vanguard, it rapidly diffuses into the parasite's acidic food vacuole. When its critical endoperoxide bridge physically contacts free iron generated during hemoglobin digestion, that bridge is violently cleaved. This cleavage generates highly reactive free radicals that inflict immense oxidative damage, tearing holes in internal organelles and rapidly halting energy production. With the vast majority of the parasite burden completely destroyed, the critical second phase of the drug takes over. Lumefantrine acts as the sweeper to eliminate residual survivors. This graphic shows lumefantrine binding directly to the free toxic heme. This creates an enzyme blockade, physically blocking the heme polymerase enzyme from crystallizing the waste into safe hemozoin. Unable to process its waste, the parasite suffers lethal autointoxication. Toxic intermediates accumulate until they cause the violent rupture of the vacuole membrane from the inside out. This dual-action therapy succeeds by weaponizing the parasite's own metabolic engines and waste management systems against it. This chart maps the 7-day timeline of parasite clearance. Artemether's ultra-short half-life of under 2 hours still delivers a massive 10,000-fold reduction in parasite biomass. Lumefantrine compensates for artemether's quick disappearance by maintaining a much longer half-life of 3 to 6 days.
This extended persistence is what sweeps up the fractional remaining parasites to prevent recrudescence of the disease. Translating this molecular mechanism into clinical success relies on a critical pharmacokinetic imperative. Lumefantrine is highly lipophilic. Marcus must take the medication with a high-fat meal or whole milk to trigger fat-dependent absorption, increasing the relative bioavailability by up to 16-fold. Without this specific dietary intervention, the sweeper drug fails to reach the concentration threshold required to block heme polymerization, guaranteeing treatment failure despite the correct prescription. The clinical outcome is excellent. With adherence to the 3-day ACT regimen, Marcus's smears will show rapid clearance and fever resolves within 72 hours. Unlike other species, Falciparum relies entirely on the erythrocytic blood cycle. Because it lacks a dormant hepatic hypnozoid stage in the liver, Marcus does not require post-treatment anti-relapse therapy. Successfully treating this complex infection requires synthesizing geographical epidemiology, evaluating the microscopic evidence, and precise molecular pharmacology. By utilizing synergistic pharmacokinetics to target the blood stage, the blood schizonticide alone provides a full, definitive cure.